Menezes, and I'm so glad to be able to join you this afternoon to welcome each and every one of you to this Global Health Student Conversation series. For some time now, as you know, the pandemic has made it very difficult for all of us to travel and see each other. And this is a great way for us to connect. We are excited to have our students from the College of Public Health at USF, as well as students from the University of San Francisco de Quito to participate. And I think you are medical students to participate in this conversation series and to talk all about COVID-19 as well as the microbiology and the immunology of COVID-19. I know there's a lot to learn. We have our expert here in Dr. Reina Ortiz, as well as Dr. Rojas from your side. And we are delighted that you are able to join this afternoon. And that I think there's much to learn from each other and to enjoy and participate as much as you can. And feel free to ask as many questions as you can of each other. And one thing I would suggest is this is a way for you to also connect with each other and learn about each other's cultures. And so stay in touch, make friends through this conversation series, and let each other know what you are doing, because this could be a way for you to connect for your future as well. So I hope that you will continue to this conversation, and I hope to see some of you visiting us at USF in Tampa soon. So greetings again and enjoy the rest of the afternoon.
Thank you very much, Dr. Menezes, for that kind introduction. Indeed, I think this is a great opportunity for students to learn from each other, and for us as faculty as well, to learn from their experiences and what they have been doing through the pandemic. Probably, I think one way to start this off would be maybe if we can give a brief introduction of each person who is here, their names, their career pathways, their choices in terms of academics and where they're heading, so that we start getting to know each other. So probably to make it easier, let me start just brief introduction of myself. My name is Miguel Ortiz. I am a physician and a public health scientist. My interest is in the prevention and control of infectious diseases. The bulk of my work has been on HIV/AIDS prevention, but I also do work on other viral diseases like Zika virus and dengue and other infectious diseases that are not necessarily viral, like malaria. With COVID, I was very interested in supporting the community as much as we could. I was part of research projects. We have some publications, but I also was active doing community engagement talks just to try to get information out to people. Because one of the things that I noticed very early on the pandemic is that there were a lot of questions, and obviously there were not many answers, because this is a completely new disease. So just getting across that message, this is a new disease, there are more questions than answers, and what we know, it's infer from what we know from other diseases and other viruses and other similar conditions, but this knowledge may change, so that then people wouldn't be surprised when knowledge did change with time. Try to avoid mistrust and miscommunication on the way. I was part of Universidad San Francisco. I did my master's in microbiology from Universidad San Francisco. Dr. Rojas and I were classmates both in microbiology, but also in the School of Medicine. We went to the same School of Medicine as well. We know each other very well as well. And it is a pleasure for me to host this first conversation, a global health student conversation. And I look forward to learning from you. And I look forward to, more than anything, for these connections to happen today, for these friendships and these bi-directional learning, or rather multi-directional learning, to happen this afternoon. So with that, probably I leave the floor open for you to introduce yourselves. I don't know, maybe Dr. Menezes or Jesse, yeah, you want to go ahead.
Yes, so I'll quickly introduce myself, and then I think we can start afterwards with the students from USF, and then we can move on to the students from Universidad San Francisco de Quito. So my name is Jesse Casanova. I'm the Assistant Director for International Programs for USF Health. And we're definitely happy to be hosting this conversation series with all of you.
Did you want me to introduce myself again? Quick. I think maybe I didn't do proper introductions when I was saying a welcome, but I am I'm also the Assistant Vice President for International for USF Health and the Assistant Dean for International for the College of Medicine. And in that role, we've been hosting this Global Health Conversation series, and we're so excited that all of you are here. So with that, I'm going to ask our students to go ahead and introduce themselves.
Go ahead, Michaela.
Hi, Dr. Reina, how are you?
Good to see you.
Good to see you. So hi, everyone. My name is Michaela McMahon. I am a second year master's student in the College of Public Health at USF. I'm concentrating in global communicable disease, and some things I'm interested in is basically environmental health, looking at anthropogenic activity and climate change and their effects on infectious diseases. Thank you.
Would you mind naming the next person to go?
I think Katarina or Nkunda is here. Either one.
I can go ahead and go, Michaela.
Okay, hey, Katarina.
Hi, everyone. My name is Katarina Chipman. I am a second year MPH student here at USF, and I'm a dual concentration in Epi and global health. I'm a former ICU nurse, so I kind of made a little bit of a career change. But I'm hoping to work with outbreak surveillance and response in emergent situations internationally, like refugee camps. So, Nkunda, do you want to go next?
Yes, please.
Hi, my name is Nkunda Basinje, and I'm also a second year master's student at USF, College of Public Health. I'm concentrating in epidemiology and global communicable diseases. My main interests eventually are maternal and child health, which basically I want to, I may live in the US, but my family is in Uganda, East Africa. So a lot of what I do and a lot of what I try to attend are to do with how different diseases affect people around the globe, but specifically third world countries. So I'm very excited to be here. So thank you.
Thank you, Nkunda. Do you think you can name the next person to go?
I think, is Connor here?
I don't see him here, no.
Connor has class.
Oh, okay. Yeah, so I think that might be it for USF. I'm not too sure.
Hi. I'm a USF student as well. My name is Riley Phillips. And I'm a first year master's student here in the College of Public Health, and my concentration is global health. And my interests include improving conditions in health conditions in developing countries. And I was interested in this conversation because I come from a more like psychological background. My undergraduate degree was in psychology, and I used to work at a psychology practice, and we saw a lot of kids coming in with learning issues and mental health disorders. And I saw how COVID affected them, and just how simple things just like wearing a mask really affected them. So I kind of come at this from that perspective. And I'm also a travel agent on the side, which has been very interesting during the time of COVID, and how people are traveling right now, or if you're not, or if you are. So that's been very interesting. So I have a unique perspective. And yeah, I think that's about it from me. I just wanted to say something. So.
Thank you, Riley. Do you think you can name the next person?
Yeah, I'll just pick somebody. Is it Audrey Bellin? Has she gone yet?
Audrey Belen.
Bellin?
Yeah.
I'm just picking people off the list I see here.
Okay, thank you so much, Audrey Belen. I think, are you with us? Your name might be different.
I'm not sure.
If you're speaking, you are muted.
Yeah, she's muted now. I don't know.
Yeah, she's muted. Okay, let's go with the next person on the list. Santiago Naranjo.
Yeah.
Hello to everyone. Are you hearing me?
Yes, we can hear you.
Hey. Hello, my name is Santiago Naranjo. Well, as you know, I'm the Universidad San Francisco de Quito student. I'm studying my second year in my master's degree in microbiology. I'm actually doing my thesis in virus, which is my interest now. I'm actually beginning the thesis in Oropuche virus. So that's, I think, something, the most important thing about me. I also love politics and health politics. It's something, it's a personal interest. So that's why I like this. I actually asked Patricio to participate in these conversations. So thank you.
Excellent, excellent. Thank you so much, Santiago. We're doing a symposium on global health diplomacy in STMH this year, something that you might be interested in, but we can certainly talk about that later. And actually, Katharina, who joined today, she was in my global health diplomacy class as well this past summer. Santiago, would you mind naming the next person to introduce themselves?
Yeah, my pleasure. Dario Cueva.
Hello, everyone. I'm Dario. First year master student here at the Universidad San Francisco de Quito. I'm doing microbiology as well. And I am pretty much interested right now studying microbial resistance and specifically to use bacteriophages to try to tackle bacteria that have developed antibiotic resistance. So my background is in biotechnology engineering. I also have a master's in quality management, and now I would like to switch paths and perhaps to go into the clinical field. I would like, hopefully in the future, to study phage therapy in clinical trials and stuff like that, especially within biofilms, which is a concern with certain pathogens, and that's pretty much it. Thank you for the invitation.
Thank you, Dario. Thank you very much. Antimicrobial resistance is indeed a concern. Now we are very much concerned about COVID-19, and I'm very focused on HIV as well. But antimicrobial resistance is something that we need to keep in mind in the horizon. It might be an issue. Audrey, I see your hands raised up.
Hi, everyone. Can you hear me?
Yes, we can.
I had some technical issues before, so I'm just going to go ahead and introduce myself now. I'm a first-year graduate student for the Master's in Public Health. My concentration is in global communicable disease. I'm originally from Dominican Republic. I'm a medical doctor back home, so actually my background is more clinical. I actually was working during the pandemic in the internal medicine department in my country. So I actually had the experience of, like first line provider in that moment. And now I'm on the field of public health, which is on its hand, but it's like a different perspective. And I'm very glad to be with all of you today.
Thank you, Audrey. indeed important work during the pandemic as well. Oh, Audrey, would you mind naming the next person to go?
Sure, just give me 1 second. Flores Galo.
Thank you, Audrey. Galo,
Yeah, hello.
Yeah.
Yep. Hello, everyone. Can you hear me?
Yes.
Okay. So my name is Galo Flores. I'm a student on the first year of a master's degree in microbiology here in the Universidad of San Francisco de Quito. In my undergraduate, I work a little bit with antibiotic resistance on E. coli, Salmonella, and Campylobacter, and also a little bit with parasites regarding Giardia and what assemblages are present here in Ecuador. And it looks like for my master's thesis, I'm going to be working also with antibiotic resistance and how these plasmids are passed through different genera. So that's it, and I'm excited to be here. Thank you.
Excellent. Thank you so much, Galo. Again, antimicrobial resistant, we cannot stress enough the importance of it. Would you mind naming the next person to go?
Yeah, Maria Jose.
Hello, everyone. My name is Maria Jose Mora, and I'm a student here at the University of San Francisco de Quito. My bachelor's degree was in biology. I studied at UMass Lowell, and right now I'm working on my thesis for my master's in human papillomavirus and human leukocyte antigen to see if there is any relationship between the HLAs that we express and the genotypes of HPV that we can also have. So yeah, that's pretty much it. Thank you.
Thank you, Maria Jose. Very interesting thesis. I'd like to see what you find. Would you mind naming the next person to go?
Ronnie.
Thank you.
Can everyone hear me properly?
Yes, we can.
Yes. Hey, my name is Ronnie, and during my undergrad, I completed a bachelor degrees in biotechnology, and I'm currently a first year master's student here at the University of San Francisco de Quito. And so right now, I haven't defined yet what I will be doing for a project here at during my master's degree, but pretty much it will be on trying new compounds for treating leishmanias and see their effectiveness and like kind of everything related to that. And my background as a biotechnologist, I completed my degree in nanotech at the University of Queensland, and I hope in the future try to use my undergrad knowledge and like drug discovery and to treat well, parasites at the first stage, and then trying to expand it to other fields. That's it. Thank you very much, and I'm really happy to be here.
Thank you, Rennie. Very interesting. Drug discovery for neglected tropical diseases. It's something that is required, needed, just because they're neglected, right? So thanks for doing that. Would you mind naming the next person?
Yes. So who else is here? Sarah, maybe? Sarah Cifuentes.
Hello, everyone. My name is Sara Cifuentes. I am a medical doctor and microbiologist, and I am a PhD student at Universidad San Francisco de Quito. So this is my third year in the program in microbiology. And I have been working with the gut resistance in humans. And the first part of my work was trying to understand how the probiotics can modify the human gut resistance in patients treated with an H. pylori eradication therapy. So we found interesting results using Saccharomyces boulardii. And the next part of my work is studying the resistance in children that live close or far from animals. So my interest basically is metagenomics and the resistance. So that's it.
Thank you very much, Sarah. Great to see you, by the way. I know Sarah also from a couple of years ago. It's great to see you progressing in the PhD program. Resistome, microbiota, metagenomics, you are a cutting edge, so that's great. We have a next year's pre-meeting course estimate is going to be on metagenomics as well. So keep an eye on that. I'm sorry, I keep bringing STMH. We're having the annual meeting this year. It starts tomorrow. I'm the president of the STMH Committee on Global Health. So I've been very active in the activities of the group. And I do encourage you to join if you haven't, because if you're working on tropical medicine, if you're working on global health, it's a good professional organization to be part of. And they have special rates for students and for people from developing nations or low middle income countries as well. Sarah, would you mind naming the next person to present?
I don't know. Maybe all of us.
I think Jamie Smith.
I don't know.
Is Jamie Smith here?
Hi, yes, I'm here. My name is Jamie Smith. I work with Jesse and Tina. I work for USF Medicine International. I am the International Observership Coordinator, and I'm also a program assistant that helps out with Jesse. But I am glad to be here. Thank you.
Thank you, Jamie. And since we are in the office, back in the office, maybe Tina can follow.
Sure. Let me try to make my video on. Hi, my name is Tina. I'm the travel coordinator and program assistant for USF Health International. So I work along with Jesse and Jamie. Welcome, everyone.
Thank you very much. And I think we had Jana joining later in the presentation as well. I think I saw Jana here. Yeah. Jana, would you want to introduce yourself?
Sure. Sorry, I was a little bit late. Hi, I'm Jana Bastardo. I'm a doctor from the Dominican Republic. I'm currently a student of Master of Public Health program at USF with the concentration of global health and epidemiology. And yeah, I have some experience working in primary care units in the Dominican Republic while I was involved in both medical practice and public health. So it's nice to be here. Thank you.
Thank you, Jana. Thank you for joining. Jana is also very interested in the community-oriented the primary care, it seems. As I talked with her a couple of weeks ago, which is one of the tools that we learn in the global health class. So thank you, Jana, for joining. I think Belén Atienza.
Hello. Hello, everyone. My name is Belén. I'm already finished my master in microbiology, and I'm doing my thesis in biofilms, candida biofilms. My background is I am medical doctor, and I used to work in ICU and in ICU in neonatal intensive care, and so biofilms is a great problem in this area, and this is my concentration, study biofilms.
Thank you so much, Belén. Biofilms, this community of bacteria living together under one big tent, so to speak. It's definitely a topic of interest in clinical medicine, but in other parts of biology as well. So before we get started with this conversation that you are going to lead and have, we just wanted to give some information to put things in context. And again, Dr. Silva has had some last minute challenges, and sadly he's not able to join us today. But let me go through some of the information that he had here to share, and I hope I can read his mind properly. But what we have discussed is, first, we are going to talk about a brief introduction of virological characteristics of coronaviruses in general terms. You know, coronaviruses is a family of viruses. The family is Coronaviridae. They belong to the order Nidovirales. And you have alpha, beta, and gamma coronaviruses. And coronaviruses usually tend to cause a cold. Some of them can cause common cold in humans, but not major diseases, no major diseases to human until SARS coronavirus. You might remember the severe acute respiratory syndrome outbreak that started around 2003, towards the end of 2003 as well. That was a completely new disease, just like COVID. It was a new disease, a new type of atypical pneumonia. When we talk about pneumonia, pneumonia is an infection of the lungs. And when we talk about pneumonia, we usually talk about pneumonia that is caused by bacteria. And the bacteria that cause pneumonia usually have very classic symptoms of the disease that include a fever, cough, and the production of a sputum. But sometimes we have what we call atypical pneumonia. That is a pneumonia that doesn't have the typical symptoms. There might be fever, there might be malaise and general symptoms, but there's not cough production as usually there is in pneumonia, and even the x-rays look different. So SARS coronavirus, when it started, what we only thing that we knew is it was a cause of atypical pneumonia. There was a cluster of cases of atypical pneumonia. We know that probably the story seems to be that the virus was contained in the forested areas of rural China, and then the virus jumped species from bats into civets and other mammals. And then in China, they tend to have these fresh markets, fresh meat markets. So it seems like a doctor who was working with the WHO went to one of these fresh markets and got infected with the coronavirus. And then this doctor was on his way out of China, so he stopped in Hong Kong in an intercontinental hotel, and then he became a super spreader host. He was able to transmit SARS to many people, about 10 to 20 people, if I remember correctly. And from there, he went on to Southeast Asia. And from Hong Kong, the disease really spread out. Hong Kong being a hub of international travel, the disease really spread out throughout different continents. It spread out rapidly. It had initially a high mortality rate, over 30%. So this was a bit scary because it was a new respiratory disease. It was viral, induced a severe acute respiratory syndrome, hence the name SARS. And we didn't know much about it, and it was causing a global outbreak. It went to Canada, to the United States, to Europe. It was really spreading globally. And then we were able to contain through public health measures and immediately diagnostic tests, and therapeutics started to be tested and researched, and we were able to contain that outbreak. And mostly because SARS coronavirus 1 was not as capable of person-to-person transmission. There is person-to-person transmission, but definitely not to the same level that COVID has, for instance. And from that time onwards, we really didn't hear much more about coronaviruses until a new disease, another respiratory syndrome caused by a coronavirus was identified around 2012, and that was called the Middle East Respiratory Syndrome because it was identified in Saudi Arabia in the Middle East. Started to spread globally as well. Here, the intermediary hosts seem to be camels. Until COVID-19 started, we're still keeping track of MERS coronavirus. A few cases of MERS coronavirus appeared outside Saudi Arabia. We had one here in Orlando, actually. There were cases reported in Korea. And so Korea had borne the brunt of the first SARS international outbreak. And they were also affected by MERS coronavirus outbreak. So Korea was already working on a plan to contain pandemics or potentially pandemic diseases. And so was Taiwan, by the way. And then from there, really, our next big coronavirus disease appears with COVID-19. COVID-19, you may remember December 31st, China reported to the WHO a cluster of atypical pneumonia cases that became, by January 12th, that they shared the genome of the virus, and it was identified to be very close to SARS coronavirus. Until that point, the virus had been called novel coronavirus 2, 2019, novel coronavirus 2019, very, very straightforward. It was a new coronavirus and it was discovered in 2019. The sequence was shared, and after much deliberation, the ICTV, the International Committee on the Taxonomy of Viruses, decided that this was a close relative to the first SARS coronavirus and named this SARS coronavirus 2. And the disease that is caused by SARS coronavirus 2 was named COVID-19. That, again, very straightforward, that comes from coronavirus disease 2019, COVID-19, disease caused by coronavirus that appeared in 2019. And one thing that you may notice that they were very intentional in the way they chose the name of the disease. They didn't say like Asian virus, or because in the past we tended to name viruses based on geographic location. We used to do that. But recently, like the Zika virus, for instance, Zika virus is named Zika virus because it was first discovered in the Zika forest of Uganda. But with COVID-19, they wanted to avoid to point to any particular geographic location to avoid discrimination and hate against any particular population group. Therefore, the name of the disease was COVID-19. The name of the virus was SARS coronavirus 2. And if you want to learn more about ICTV and viruses in general, please do take my virology class in the spring next year, where we go into this into that information with more detail. But just as all coronaviruses, SARS coronavirus is single-stranded RNA positive virus. Because it's an RNA viruses, you will understand that the rate of mutation of this virus is higher than, say, DNA viruses. So just virology 101, viruses can either have a DNA or an RNA genome, and the way they reproduce is through the use of polymerases. RNA polymerases are they have lower fidelity, if you will, than DNA polymerases. What do I mean by this? When a DNA polymerase is working, the DNA polymerase will not only copy the new chain of DNA based on the template, but it has a proofreading function. What does that mean? It goes back to what has already been synthesized and checks for a perfect matching. And if there's no perfect match, then it will take off the nucleotide that was misplaced, and it will put in the right nucleotide. So that proofreading ability makes that the DNA polymerases reduce the chance of inducing mutations. But for RNA viruses, the RNA polymerases, they usually lack this proofreading capacity. Therefore, they are more likely to introduce mutations. Now, think about variants. We've been talking about variants of COVID so often. This is the reason why, because RNA polymerases are more likely to introduce mutations, and therefore there is more likely to appear every once in a while to appear a new version of the virus that is slightly different, but it has different, at least different virulence or pathogenicity. So that's a overall in like a brief introduction of SARS coronavirus and its virology. I don't want to go into more details because that's what we were looking forward, that this will be part of your cross communication today. in terms of public health, from a public health perspective and epidemiological perspective, we know that COVID-19 is caused by SARS coronavirus 2. The initial outbreak, although was reported in December 31st by China to the WHO, we know that the first cases that were actually actively being reported in the news outlets and the whistleblower from China were from early to mid-December, but recent research suggests that probably since summer, or even before summer of 2019, the virus was already circulating. It was officially first recognized in Wuhan, a city in China. And as I told you, the name of the virus was initially novel coronavirus 2019, and then it was named SARS coronavirus 2. The World Health Organization declared a SARS coronavirus 2, or rather the COVID-19 pandemic, and sorry, at that point it wasn't a pandemic. The COVID-19 spread, it was named a public health emergency of international concern by January 30th. A public health emergency of international concern is a mechanism that is enshrined in the international health regulations. Back to global health diplomacy, right? So the international health regulation is this binding a treaty that almost all nations of the world have signed, and basically there's one portion of the treaty that says that if there's an infectious disease that is crossing borders, then the WHO has the capacity to declare it a public health emergency of international concern. That only happens under the recommendation by a specific task force or committee that is put together to analyze the emergency. Few diseases have been declared a public health emergency of international concern previously, including Ebola virus outbreak, especially the one in West Africa, about 5 to 7 years ago, and the neurologic complications of Zika virus. Not Zika virus itself, but the neurological complications that were observed in the infants that were born of mothers with Zika virus. You might remember the most notorious of those ones were microcephaly, but also even in adults there were some neurological complications. So that is to say, that is just to give you a context of what does a fake means and what and how rare, what are the conditions that warrant this declaration. But by March 11, the WHO went one step further and declared COVID-19 to be a global pandemic. It's redundant, actually. If you say global pandemic, it sounds a little bit redundant. It is a pandemic. Now, before we go into the discussions, and before I share a few global figures more, I want to show you this video here. And I have 2 more videos. I won't show you the other videos, but I can certainly give you the links for you to look at.
The cause of the mysterious new virus, coronavirus. China has identified the cause of the mysterious new virus, coronavirus. Coronavirus.
There are fears a rapidly spreading virus has reached Australia.
This is a rapidly emerging situation where there is not a cause for alarm.
The first US case has been detected. There's confirmation the coronavirus has reached Australia. China is urging its citizens not to travel abroad as it struggles to contain the virus.
We will be standing up Christmas Island as a quarantine area.
Foreign nationals coming from China are now banned from entering the country.
I have today declared that the coronavirus presents a public health emergency in the United States.
Trying to contain a city of 11 million people is new to science. It has not been tried before as a public health measure.
The death toll now has risen above that of the SARS outbreak 17 years ago.
We now have a name for the disease, COVID-19.
I was at a hospital the other night where I think there were actually a few coronavirus patients, and I shook hands with everybody.
The Italian government tonight put the entire country on lockdown.
COVID-19 can be characterized as a pandemic.
We will be suspending all travel from Europe.
From Italy this evening, it just gets worse. The death toll now worse than China.
What happened in Bondi was unacceptable.
12 years of perfect employment, it all blows up in 24 hours.
More than 3 billion people in almost 70 countries and territories have been asked to stay at home.
From this evening, I must give the British people a very simple instruction. You must stay at home.
We're asking everyone to work at home if possible, postpone unnecessary travel.
आज रात 12 बजे से संपूर्ण देश में.
So together, and with the rest of the world, we face this unprecedented challenge. For many, young and old, 2020 will be the toughest year of our lives.
We've got some breaking news to bring you, and it's to do with the Prince of Wales. He has tested positive for coronavirus.
The Prime Minister, Boris Johnson, has tested positive for coronavirus.
Countries around the world have now reported more than 1 million coronavirus cases.
Prime Minister Boris Johnson has been transferred to the intensive care unit.
The city may have to temporarily bury bodies on public land if they run out of morgue space. Better days will return. We will be with our friends again. We will be with our families again. We will meet again.
Excellent. So what are your reactions to this video? Anyone?
I can go ahead and speak. As a short reaction, I think if I hadn't lived it, I would have thought it was from a movie. But of course, we all lived it. So kind of the worst case scenario of what could have happened.
Correct, right? Like this is exactly right. I remember at the beginning of the pandemic, I was telling my wife exactly that. You remember, probably remember the movie Contagion, right? So many things about that movie. Some things of the movie, obviously not everything, but it really seems like the plot of a movie, indeed. And so many first times to do something like that, like first time that the world was put in a lockdown, basically, not at the same time, but almost at the same time. Same time that we had to cancel flights across the world. The first time that we saw this massive loss of life across the world. First time that our first responders and our healthcare personnel were burnt out. I mean, it's really, it's something of this scale hadn't been experienced. Certainly it hadn't been experienced in recent modern history. And we hope that we don't get to experience something like that again. That was a short video just to show you a summary of the major things that have happened, and obviously that there's so much to cover on COVID-19 that probably was left out of the video. I'm going to stop talking now because I really want you to get into the conversation. This is just a figure to show cases of COVID-19. You have here the United States and Ecuador are being shown here, and the reason we chose these two countries in particular is because obviously this is who are in the audience. So can you guess which one is which one?
The blue one is Ecuador.
That's correct.
Because we had in April the worst part of the pandemic in our country. Mm-hmm.
That's right. The blue one is Ecuador. What you have here are rates. So you see, this is not total number of cases, these are rates. So Ecuador had much worse rates than the United States earlier this year and even last year. This is just this year here. But then we have a significant decrease in Ecuador, whereas you see that the United States have been at least 2 waves, if not 3 waves in this year. Any ideas why would that be?
Kind of chiming in on this, I know, well, in May was around the time when a lot of individuals here in the US were actually able to go and get the vaccine, and it looked like it was kind of working. And then around the summertime, that's when a lot of states started opening up and kind of lessening down on any restrictions that was put on individuals. And so a lot of people here in the US kind of took that as a, oh, the pandemic is over kind of thing. And there was already a lot of skepticism in regards to receiving the vaccine. And there was a lot of resistance in individuals getting the vaccine. So we kind of saw a spike here, like late summer, early fall, with a lot of that.
That's exactly correct. Thank you, Michaela. And you will notice that there's a projection here at the end of the slide, obviously. So what explains Ecuador's pattern? Ecuador's pattern is different.
Yeah, well, basically here, I would like to talk because I was in Guayaquil during the first wave of the pandemic. So I lived pretty much what happened there. So here in Ecuador, what happened is because of the lack of resources and stuff like that, we weren't able to detect the early cases of the disease, right? So it seemed like everything was going not that fast, but it was because there was under-testing of the disease. And then suddenly the cases spiked, and at first, at the beginning of the pandemic, there were no enough tools to test the disease. So basically, if you see the reported cases, there are not representative to what happened there. But if you get to see the rates of the excess of mortality in the country, you can see that the first wave was really aggressive, especially in Guayaquil, in the coast of the city, is because pretty much the population was unaware of how much dangerous it was to be around. But then the restrictions were applied, lockdowns, curfews, and all that, and still face masks are mandatory in the country. So that's why we have seen a decline in the cases, and also the vaccine. Even though it was kind of late to the country, it has been available for a big part of the population. I believe that our vaccination rates during the last 2 months pretty much were among the best in the world, and we pretty much are at the same vaccination rate of in the overall population. If we compare to the US, the vaccination rates are the same. So, but obviously it's not over, and we still have to take measures and see what happens there. But I think that one of the major differences is that here people really use masks in the streets and stuff like that, that is helping to contain, contrarily to what we have seen, for instance, in Israel, where once most of the population was vaccinated, they decided to take off the mask, and now we have seen spikes in their infection rates. So yeah.
Right. So you make very good points, Dario, and I would just want to highlight that you are seeing here probably the second or third wave in Ecuador as well, because the big wave was April, March last year as well in Guayaquil. That was really catastrophic. And I think what you have mentioned is important about underreporting. So even what we see here might not be the real magnitude of the impact of COVID-19. And you've spoken of important things like the use of masks, but also vaccination rates. Vaccination rates in Ecuador have been very high, and higher even than in the United States. So that a rapid deployment of a COVID vaccination, I think it's important. Not only the rate, but really this rapid deployment, I think it's important, because if you do it rapidly, the chances of mutations and variants probably is reduced, because you are containing more effectively. Because with a disease that is so easily spread like COVID-19, that has an R0 that is so high, you know, I mean, the smallest R0 for COVID-19 that I think is probably 2.3, but I've seen as high as 9 or 10. So if the disease spreads so easily, for you to even think of something close to herd immunity, you're talking about a very high percentage of the population being covered. And if you take too much time to get that a herd immunity threshold vaccinated, you might be risking a ongoing transmission and further mutations. So I think it's interesting what happened in Ecuador, and hopefully, you know, we'll be able to move the needle even higher in terms of vaccination coverage. These are the numbers of COVID-19 related deaths. Again, here you have the rates in not necessarily the numbers, but this is again the United States compared to Ecuador. Now, because of the issue for the reporting, one thing that became very quickly in our minds was that we shouldn't only be looking at the reports of people dying from COVID, but what is the excess mortality? So if in a country, usually in a month, 100 people die normally, and suddenly you have 1,000 people dying, so you have 900 people of excess mortality, right? And granted, those 900 people are not going to be direct COVID-19 deaths, but given the context of epidemiological context, you can estimate what proportion of those are a direct impact of COVID-19. And see, I talk about direct impact because there's also indirect impact of COVID-19 that can also lead to mortality, like lack of personnel and resources to address other urgent healthcare issues in the population, right? Or economic deprivation and criminality, etc. But so this map here shows you excess mortality in different parts of the world, across the world, from March 1, 2020 to September 26, 2021. And you can see how in South America and Latin America, we have among the highest excess rates reported in the world, with some areas of Europe and Russia as well. Vaccine coverage, as you can see here, is so you have Ecuador in blue and the United States in that greenish color over there. Now, so we are ready for our discussion questions, and this is where we want you to start having a conversation. And the first question is really what we will want you to do is to discuss the main virological characteristics of SARS coronavirus 2. And then what I want you to do today is to relate those virological characteristics to COVID-19's public health application, prevention and control. So I'm going to open up a free discussion here. What I wanted to have, I'm going to be quiet for the most part. I'm going to intervene only as needed, but I want the students to have a conversation on what are the main virological characteristics of SARS coronavirus 2, and how do those characteristics relate to public health prevention and control, to public health significance, in other words. So please go ahead. Belén.
I'm sorry, my English is really bad. Can I speak in Spanish and can you translate me, please, Miguel?
Sure, go ahead.
Ok, yo pienso que una de las características del virus más importantes es que es capaz de esconderse porque tiene esta zona de furina. Entonces, cuando la furina se rompe, el spike es capaz de recién ahí emerger. Mientras no se rompa la furina, el spike está escondido. Entonces, esto es lo que hace que el virus pueda esconderse tal vez del sistema inmune.
Okay, so what Belén is saying is that there is a property of the virus in which there is a protein called furin that kind of keeps the spike protein hidden. And until this furin gets broken, the spike protein cannot be expressed and cannot be recognized by the immune system.
I also want to add something to what Belen was saying, and it's that also I think another characteristic would be the virus attached to ACE receptors, and those receptors are not also in the respiratory system, but they are in other parts of the body, and that connection that it has in multiple systems, sometimes it is harder to diagnose that is COVID-19, like just by hand without, if we don't have a test. And some of the challenges that I've seen primarily in the Dominican Republic, where I saw this time of cases, is that we suspect that it was COVID-19, but then we didn't have the resources to have this person tested for that virus. So probably the doctors weren't sure to diagnose that. So the delay in that diagnosis led to not recognizing close contacts on time. And so that led to an increase of or a delay, I must say, of containing the disease in a particular community per se. I don't know if that makes sense.
Okay, thank you, January. It makes perfect sense. What I'm thinking as you guys are talking is that maybe we can have a person to volunteer to open a slide and start typing these ideas, so we can later, you can later put them together. So now you're like in a brainstorming session. So if you can type down, maybe like in a table, virological characteristic and then public health significance, and even you can put something in the middle like clinical significance, and then start filling that out. And again, I really want to be as quiet as I can. So please feel free to lead this discussion you amongst yourself. So if any student can then, volunteer to do that, another student can volunteer to lead the discussion, and then I'll be here just to provide some support as you develop this conversation.
Miguel, I'm sorry to ask this, but I have bad connection problems. So could you repeat your question for the discussion? Because in that moment, I couldn't understand the question, please.
Sure. So the question is, what are the virological characteristics of SARS coronavirus 2, and how does that relate to public health significance? You can think about prevention and control. You can think about late diagnosis, like Jana was mentioning earlier. And so what I was saying is that maybe one person can serve as a note keeper, if you will, to open up a slide and then share this slide here with everyone else, and start typing these ideas in a table. So then later you can synthesize those ideas.
Thank you.
Hi, Dr. Reina. I created a table I can share if you'd like.
Sure, thank you, Miguel. Can you please share it so everybody can see? And I see, Belen, you have your hands raised.
Thank you, Miguel. I'm sorry, I'm in my office, so maybe you're going to listen some noise. One of the most important biological characteristics of SARS-CoV-2, I think, is that the virus is transmitted in an airborne as an airborne disease. So this is like the most important thing, because until it was already proven that SARS-CoV-2 was an airborne disease, transmitted disease, most of the people, or many people, didn't want to impose those restrictions, like using the mask and that stuff. So I think that this is a really important implication of the virus.
Thank you, Belen.
Dr. Reina, are you able to allow or open the settings to allow me to share my screen?
That would be helpful. I don't know if I can do that from my end. Let me see.
And if not, I will take
Yes,
the
we can do that.
Okay, cool.
Give us a
Thank
minute.
Thank you, Jesse. Audrey.
Yes, so referring to what was just mentioned about the disease being airborne and giving a correlation of this to the public health measures, definitely it has been a big challenge for public health to deliver the message of the correct use of mask, and this being something that the population will accept. So for some countries, they will definitely accept the fact of using a mask, and they will actually feel safe using their mask. Maybe because the same fear they have to the disease, but we see
I think we missed you, Audrey.
Oh yeah, sorry. What was the last part you could hear?
I heard that people were wearing masks because it was an airborne disease.
Yes. So for some populations I was mentioning, this has been something not of a challenge, because people are actually willing to wear their masks, maybe even because of the fear to the disease. But you also have other populations in which they believe this is against like their rights, right? So they're not willing to actually use their mask. And also there has been some misinformation about the vaccine itself, about how some people think they're not gonna get the disease because they're vaccinated. So they believe they don't need any of the other measures we have tried to work on during all this time. For example, the wearing a face mask, even if you're vaccinated, and also like hand washing, social distancing. So it's important for the public health aspect, to guide the information. And this has been a really big challenge, given the fact that the disease is very easily transmitted. But also the fact that close contact kind of goes against human nature. So people are not willing to be away from their loved ones for such a long time. And this has been going on, not for months, but for years at this point.
Thank you very much. I think, Michaela, you might be missing the furin cleavage that we were mentioning earlier. So basically, maybe you can type something like F-U-R-I-N. Yeah, F-U. So you can see something like, basically that the spike protein is hidden for a period of time until it gets exposed by this molecular step. So, and then, so what would be the implications for that?
The implication could be the asymptomatic period, because we have a period that
It's
we
hidden
are
from
it's hidden, but we have the virus, so we are asymptomatic and we can spread the virus.
Okay, thank you, Belén. Maria Jose.
Okay, so one of the things that I also think it's important is that, as Belen said, we have a lot of asymptomatic cases, and different from other viruses, for COVID, for SARS-CoV-2, the incubation period, it's different or can vary a lot compared with other viruses that we have clear, for example, when the onset of symptoms start, and we can start to control the disease at that point. But for SARS-CoV-2, it's a little bit different. And that's why I think we had a lot of trouble containing the disease, and we had a lot of cases, especially at the beginning, because we didn't have the information or enough information to see how the virus or virus is transmitted, and also the symptoms when they actually start, and if they are asymptomatic cases, like how can we deal with that?
Okay, thank you, Maria Jose. So let's wait a minute until Miguel can add that to the notes.
It's okay. We can keep talking, and I'm gonna continue adding on.
Okay, excellent. Thank you, Miguel. Riley.
Hi. I just wanted to go off of what Audrey said earlier about the mask and being aerosol, like the virus being transmitted via aerosols. So we, like I mentioned before, I came to this conversation with more of a psychological perspective, and the practice that I used to work for we saw a lot of kids specifically with different types of autism and different mental health disorders and things like that. And one of the things that these kids were running into when they had to wear a mask all day at school is that they were physically having panic attacks and anxiety attacks. And if you know anything about autism and anxiety disorders, or autism specifically, is that they have a lot of sensory issues. So even like wearing a simple mask over their face is very, very tough to do. And so from that perspective, it was more about how do we protect these kids from COVID while still like taking into consideration their, if they had autism, like, do we give them breaks outside, like things like that. So there was a whole, I've been involved in a lot of those conversations. And it's not necessarily that, sometimes in these situations, it's not necessarily that they don't want to wear the mask. It's just that even like wearing a simple mask can be so anxiety producing for them. So I just kind of wanted to build off of what Audrey said earlier. So.
That's an excellent point, Audrey. I think you're bringing issues of compassion and empathy as we try to protect people from getting COVID-19. Dario?
Yeah, well, I just would like to add to something that Audrey said, and also to something that Maria Jose said about information. I think that the management of information is really important in this kind of events of disease. If you, okay, so I had, well, I guess at the beginning of the pandemic, when it just first announced the first cases in China, I think some of us were skeptical about the impact that it will have. I mean, I see from my perspective, but I think that media had a really bad impact on how we perceive risk and how we perceive danger with these kind of issues. because if you remember, I mean, when we were experiencing the outbreaks of the Ebola virus, or they were like all over the place, especially, and I can recall some news channels talking about how it was really catastrophic, and it was, but it was more, they were alarming news for places that they were not as impacted as they could be, or stuff like that. So, I mean, the overexposure of information can be something, a bad thing, especially to over alarm people and to make them anxious, and also as you get overexposed to news, perhaps you get like tired of hearing the same thing over and over again, and then you kind of think that that is not as important as it is. And also that happened with the flu pandemic on 2008. I mean, if we compare the grade of media coverage of those outbreaks to the media coverage of the COVID-19 crisis, the media at first, well, they will, of course, they will want to get profit from spreading the news and from getting attention. But I think that the way that media treats these outbreaks, like it is the end of the world when we can do something to do it. Perhaps it kind of diminishes the effort to try to control something that has a more global impact, such as this COVID-19 pandemic, which was really bad. And I mean, in terms of impact on people's lives. Also, I think there was a little bit of confusion at first when the WHO said that, okay, you don't have to wear a mask. It seems that it's not that necessary. And then they were like, you have to wear a mask. So people, especially skeptical groups of people, they are like, why do you say that at first, and now why do you say this now? Do you know what you're doing, or stuff like that? So I think that managing information is really important. In the case of Ecuador, at first there was not a consensus of what to do, how to manage curfews, how to manage lockdowns. For instance, I can remember in Guayaquil City when they were like, okay, you're just allowed to leave your home on certain days of the week, just to the grocery store or to the market and stuff like that. But they were like really restrictive. They only gave like a 6-hour period window. You could only leave home from 8 a.m. to 2 p.m., which was apparently a good idea. But the grocery stores were flooded with people during those periods of time because, you know, afterwards you weren't able to get your goods. You basically were out of food for all the week, for the rest of the week. So I think that kind of management is and policies are I mean, how to manage information are really important for this kind of cases.
Yes, I could agree with you more. Risk communication, it's extremely important. Sarah?
Okay, thank you. Another thing is about I am going to return to the part of the transmission speed of SARS-CoV-2. The public health implication is that when too many people are diseased or have the disease, so too many people go to the health system. So sometimes in our countries, for example, this problem exceeds the capabilities of health system to respond. So many people die not only because they have a severe case of SARS-CoV-2, but because they have maybe don't have attention. So that was a big problem in our country when we have the first wave, the worst part of the pandemic. So that is we have to consider this part. So the speed, the transmission and the speed can produce these exceed capabilities of the health system to respond. So that is the implication. Mm-hmm.
Yeah, we all remember the flatten the curve message that was so common at the beginning of the pandemic. Belén?
Thank you, Miguel. I just wanted to mention something I think is important for countries like my country, Ecuador, because an important problem is the fact that COVID symptoms are similar to those of other febrile diseases that are prevalent in my country. So it was really difficult at first for doctors to diagnose or even think that the sickness was COVID. So it made us really difficult also to isolate those patients and to be able to do the correct diagnosis and the correct treatment also.
Sure, absolutely, especially at the beginning of the pandemic, when it wasn't very clear. And even today, so many times people have flu-like symptoms, and then is this a common cold? Is this flu? Is this COVID? So absolutely, it's a point well taken. Okay, so thank you for that conversation. Very interesting. I want just to close up a little bit this. Michaela, would you mind showing the beginning of the table? Thank you. So we have a spike protein binding ACE2 receptors, aerosol transmission, the hiding of the spike protein, transmission mechanism, which is related to the previous one, and similar disease characteristics between COVID-19 and other diseases. Is there any other virological characteristics that we should mention that we haven't yet?
Related to ACE2 receptors, it is also important for long COVID because ACE2 are in many parts, many cells. So we don't know. We have afectación de órgano blanco, como dices eso en inglés.
Target organ complications, yeah.
Y tienes, por ejemplo, enfermedades cardíacas producidas solo por el COVID, o sea, son daño cardíaco directo producido solo por el virus. Entonces, y esto te produce un COVID largo.
Cardiovascular disease associated with COVID, yeah. Right, but going back, and we kind of need to wrap up the conversation. So is there any other virological characteristic that we should be listing that it's not yet in the table? Sarah?
I don't know how to introduce in this part, but it's the physics around the transmission of the virus. For example, I read something about this many months ago about the humidity in the room. So that can be an important thing in order to reduce or increase the capacity of the virus to be transmitted. For example, when there is humidity, I don't know, maybe 80%, the virus can place to the, I don't know, how do you say, cae al suelo.
Yeah, it falls to the floor.
I'm sorry?
Falls to the floor.
Yes, falls to floor faster than when there are less humidity. So I don't know if it is important, because for countries where there are different they have winter, they have a spring, and this part is very important, because in our country maybe we maintain the same humidity. I don't know, but in other countries can be a critical part when you try to reduce the transmission. Some experts in the aerial part of the mechanism of the transmission are very concerned about that, the humidity and other parts around the virus. But I don't know, how do you say that in this part? Yeah.
Absolutely. No, I agree with you, Sarah, that not only the biological characteristics are to be kept in mind, but also other characteristics of the transmission chain. We are really on the time. So Jana and Belen, and then we'll wrap it up.
Okay, I'll be quick. I think I don't know if there are too many studies on this, but since we have many variants now of the COVID-19, we have the Delta, the Alpha, the Beta, and maybe we will have more. So that is another characteristic that we should keep in mind since we are dealing with COVID-19. So it can change to a more complicated variant, and then we can have another one that any of the vaccines that we have right now could work on that. So that should be something that it should be good to keep it in mind.
Absolutely. And I think the biological characteristic that is related to that is the RNA genome, right? So the RNA genome makes these variants more likely to happen. And then you have the variants having different virulence and different transmission capacities as well. Belen?
Yes, I just wanted to mention some positive things, because we have focused principally on negative things about COVID, but something important is that its physical characteristics, such as UV light sensitivity and alcohol sensitivity. So these things help us to control the disease and to establish public health measures to control the disease.
Absolutely. The stability of the virus in the environment, right? How stable is the virus in the environment? It will help us devise appropriate prevention and control measures. This has been great. Thank you so much. I'm really happy. I'm excited. I'm just sad that the time flew away so fast. Here's what I propose, and this is just a proposition. We can continue this conversation via email. I guess, Jesse, we have the emails of everybody who participated today, right?
Yes.
Right. So maybe we can put together an email to put everyone together and then continue the conversation, because what I'm envisioning is this table to be further developed. And maybe what I would encourage the students to do is to add citations to each one of the points that you're making to make it evidence-based. And then once the table is fully developed, we can even develop some graphs to show these pathways or connections. And then maybe we can publish that all together, either as a short piece in a peer-reviewed journal, or even a social media snippets, talking about information, communicating information, and being able to do it so in a manner that does not overload people, but that at the same time keeps them engaged with the right information, because there's so much misinformation and mistrust generated about COVID-19. And the example that Dario brought, I think it was Dario, about the WHO changing positions, the CDC changing positions, that definitely it does not help with the trust in the population. So if you all agree with this, or at least most of you do, I would encourage you to do that, and then I'll be more than glad to support you doing that. And maybe what we can do, I'm excited. I don't know about you guys, but I'm excited. So maybe we can continue this conversation. Well, December is here, so maybe in January we can continue the conversation if everyone wants to do that. Well, on my end, I said I would keep quiet, but I want to Miguel, if you don't mind, I want to show a video before we finish, a very short video. If you can bear with me a few more minutes.
Okay, I'll stop sharing right now.
Don't worry. Yeah. Perfect. So let me show you this, because we had another question that we wanted to go with you, but I mean, this was great. I do appreciate your input on this. Let me show you a quick video here.
Find gifts you'll love to give as much as they'll love to get. Macy's holiday gift.
I'm not advertising Macy's.
The COVID-19 pandemic has transformed all our lives. Lockdowns have forced us to change how we socialize, how we shop, how we work. But as vaccination rates rise, parts of the world are opening up.
It's a wonderful feeling to go back to a festival like this again.
But which changes are temporary and what's transformed for good? To answer that question, The Economist has crunched data to create a groundbreaking new index.
The amazing thing about this pandemic compared with all previous pandemics is the amount of data we have.
The results show that the world is never going to be the same again. This is not the first time a pandemic has changed the world. Historic.
Okay, I'm going to stop it there in the interest of time, but I will share this link via email. But the main part of the message that I wanted to give you with that video is there, that things have changed, and probably things have changed for good. And now we have to think about what is the future going to look like in terms of COVID. And I think working through this analysis of virology and public health can help us have an insight on that. I will share the link. It's a very interesting video. It's a new index that was created by The Economist. So I encourage you to take a look at that. So with that, I would want to thank everyone for being here, for your participation, for your enthusiasm. Unless there's anything else that we need to do, Jesse, before we finish.
Yes, actually, before we sign off, I wanted to get a few photos from everyone. Can we have everyone turn their cameras on? All right, we have a few more. Oh man, everyone looks better than me. I'm like this. Okay, I'm gonna take a few screenshots. So here's the first one. Everyone smile. 1, 2, 3. All right, I'm gonna do one more. All right. Everyone make a goofy face. Make a funny face. 1, 2, 3. Thank you, everyone.
Thank you, Jesse. Have a good one. Bye.
Bye.